Hi, everyone. Welcome to the 100th Stanford MedAI Group Exchange session. This week, we have Aishik Konwer from Stony Brook University here with us to talk about his work on data-efficient representation learning for medical vision. Aishik is a final year PhD student in the computer science department at Stony Brook University, New York. He works in the imaging informatics for precision medicine Imagine lab, supervised by Dr. Prateek Prasanna. His research in medical vision focuses on development of algorithms that leverage meta-learning, few-shot learning, self-supervised learning, and knowledge distillation techniques to tackle challenges associated with imperfect data in medical imaging. So, Aishik, thank you very much for joining us today. Before we start, do you have any preference on how you would like to take questions?
I can take questions like either way on the fly or like at the end. Like if anyone has any questions, they can just stop me and ask it.
Thank you very much. So everyone, let's try to make this session as interactive as possible. And without further ado, let me hand it over to Aishik.
Thanks, Samara, for introducing me and inviting me to this MedAI talk. So I'm a senior PhD student like Aishik, who is a senior PhD student at Computer Science Department, Stony Brook. And I will be presenting today the topic embracing imperfection in medical vision. And I will be focusing on a couple of data efficient representation learning techniques that I have done in the past 3 years of my PhD. And so let's get started. So there can be different imperfect data scenarios in the medical imaging. One of them can be absence of expensive annotations, in which there are methods like few-shot learning, supervised learning, which can come into play. Then there can be limited temporal patient data because most of the data that is collected from the patients are like snapshot, and a lot of the patients are lost in the follow-up. So the follow-up cases are not registered, and there are very few patients from whom we can have the temporal data. So yeah, there is a limited temporal data. Then we have small data sets. Some of the data sets are very much geared towards a particular task, and the quantity of those data sets, the quantity of images can be very small. Fourth of them is missingness of modalities in the multimodal data. So for example, if we are using multiple modalities of a particular patient to perform a particular task, then there can be scenarios where some of the modalities are missing in those multimodal data. And there are techniques which handle this missingness of the modalities. And last of all, there can be cross-domain discrepancies or inner annotation variations, where some techniques like domain adaptation comes into play. So these are broadly the 5 scenarios of imperfect data in medical imaging. And today I will focus on these 2 topics, that is utilizing the limited temporal information, that is temporal information, though it is limited, how we can utilize it in a better way. And secondly is the training strategies which we can propose to tackle the missingness of modalities in a multimodal sort of framework. So first I will go through how we can utilize limited temporal information through a framework. Now, I want to say why we need the temporal imaging data. So expert readers like radiologists and pathologists, they usually use a baseline medical image, that is a snapshot medical image, as you can see here, the leftmost part of both the radiology and the histopathology data sets to determine the disease. And then subsequently treatment procedures, devising treatment procedures and so on. But it's very hard to just say everything from the baseline image. So it requires in order to get the prognosis or the trajectory of the disease, it's very important to have some of the follow-up cases as well, that is the temporal images. But temporal images are used by the traditional machine learning frameworks in this phase. These are serial patient CT scans, and they are treated with radiation therapy. These are lung cancer CT scans. As you can see, the lung nodules, as they receive the radiation therapy, the patients, the lung nodule disappears, and then this is a case of semantic dementia, where the right temporal and the left temporal lobes, they incur changes. So the frameworks which are currently in use are basically solely using the temporal data in this way, like a CNN, RNN type of framework, and then they are trying to classify something. or LSTM sort of framework where the lung CTs are going in and they are trying to classify the patients with and without the malignant progression. So the left one is a lung cancer framework and the right one is a framework for the COVID-19 malignant progression. But in these methodologies, they fully utilize the limited temporal data, but these methodologies have the limitations in a way that they can only utilize the temporal data. So what we are doing in our case is, I will go through the two works. So snapshot images are like plenty. So most of the medical data sets, they are using snapshot. By snapshot images, I mean baseline images. So as you can see, the most of the clinical prediction tasks, they use the snapshot images. On the other hand, the temporal images, they contain some vital information about disease progression, that is the prognosis, but they're limited in nature, like they are available for only a fraction of subjects. Say snapshot images are available for 100 patients and only 10 of them will have these temporal images, serial images. And another thing is that these temporal images are often missing in the inference phase. They can be available in the training, but they're not present in the testing phase. So these are the different cases that can happen, like sequential COVID-19 chest X-ray or MRI scans or CT scans, from which the people get the outcome prediction. So our method is how we can jointly exploit this complementary information coming from the temporal images in order to better the performance of the predictions coming from the snapshot images. So the goal is to design a framework that utilizes the partially available temporal data, that is the data which is available for only a fraction of patients, to recalibrate the features that are learned by a single time point prediction pipeline, that is the snapshot prediction pipelines. So we can use temporal sequence. How can temporal sequences be made? Like how can we align these two domains? We can use hierarchical attention in a temporal convolutional network, so by which we are selecting the most informative image of the entire temporal sequence, because in a temporal image, we have to bring it to the same domain as a snapshot image. So we have to select an optimal representation that can be compared with the snapshot representation. That's why we have to choose only one image or one optimal representation. We are using a hierarchical attention-based DCN to perform that task. And then how are we aligning those distributions? We are employing a maximum mean discrepancy loss in the feature space in order to align the image that we are getting from the TCN and the snapshot image. So I will go through an overview of our framework. This is the temporal progression learning, which is trained at first and then it's frozen. So as you can see here, these are knee osteoarthritis X-ray data, and sequential images of knee osteoarthritis X-ray data, which we are passing through a temporal ConvNet, and there is a hierarchical attention after each layer of the temporal ConvNet, which I will go through details in the next couple of slides. And we select the optimal representation. While selecting the optimal representation, some attention can be like given to one time point, and less attention, more and less attention are given to different time points. So in this way, we construct the optimal representation. And then there is the snapshot learning. We use the self-supervised vision transformer. We get the target data, the snapshot target data that we have, and then fine-tune that vision transformer. And finally, what we are doing, we are using a recalibration network in order to do the feature matching between the frozen optimal representation coming from the temporal part and the snapshot representation. And this recalibration loss is a weighted summation of the maximum mean discrepancy loss and the prediction loss, which can be a cross entropy or ordinal loss. And what
Aishik, can I have a quick question here?
Yeah, sure.
So is this for recalibration of the network, is the temporal sequence of the images and the snapshot image, they're coming from the same patient, same sample, or can they come from like two different patients?
It can come from two different patients, like it may not come from the same sample.
Okay, so both of these branches, they essentially give you representation of either like a single image or a temporal sequence of the image. None of these branches is actually doing the prediction yet, right?
None of it is doing the prediction yet, but what the temporal progression learning branch is exploiting is basically some of the severity levels that we have, which I will go into details. So they're using severity labels as ground truth for
And
capturing the
severity labels are coming from they're domain specific, like these severity labels, for example, in this case would be this disease specific labels, right?
yeah, disease specific. Like
Disease specific. Okay.
this is related to osteoarthritis.
Osteoarthritis. Okay.
Yeah.
Okay. Okay. Thank you.
Any more questions? I will proceed then. So the snapshot
Sorry, I have a question.
Yeah, sure.
So how, what is the difference between the features that this TCN is capturing, and if a vision transformer was used instead? I mean,
Okay,
instead of using TCN, if a visual transformer was used, what is the difference between the two architectures or the features that you are trying to capture?
Yeah, so we have seen from a bunch of temporal images that we have seen distributions of the disease. Like there can be different distributions. Say disease is like reaching its peak in the middle of a time sequence, and then suddenly it's decreasing, or it's monotonically increasing to its peak. So these are the different disease progression patterns which we can only exploit from the temporal data. So those severity levels we are using as ground truth to basically train this TCN. So TCN basically gives us of the entire sequence one representation which can best describe the disease.
Okay. Okay.
Yeah, which can basically guide us to if you only have snapshot data, then the temporal information that we are getting as an auxiliary thing, it can guide us to see what the patient basically that snapshot data will fit somewhere in that temporal data, and that TCN will figure out those data patterns. Yeah.
Okay, so basically those snapshots are fed in to get at the same time, or
no, it's not fed in at the same time because the temporal representations are actually frozen.
Okay.
And then we are using the snapshot.
Okay. All right. Okay. That makes sense.
Okay. So in the snapshot pipeline, as you can see, this is the self-supervised vision transformer pipeline. So we have the input image, which we are corrupting with different techniques, like it can be jittering, or it can be Gaussian noise, or random replacement of the grids. And then we are capturing the embeddings and passing them through the vision transformer. There are two types of losses which are coming into play here. This is the reconstruction loss, where we are trying to reconstruct the input image. And second of all, there is the contrastive loss. So basically, we do two type of corrupted augmentations on the same input image. And between these two corrupted augmentations, there is a positive contrastive loss. And between the augmentations of different image, there is a negative contrastive loss. So using both these two contrastive losses, we are training the vision transformer in a self-supervised fashion. So these are the two snapshot losses, as you can see here, the reconstruction loss and the contrastive loss. And the proposed framework, as you can see, I'm going into more details here. So these are the sequential images that we have. At first, we basically divide them into separate grids in order to get a more granular level of learning. So each of the lungs, the left lung and the right lung, is divided into 3 separate grids. And as a ground truth, we have the severity levels of each of these grids, of each of these time points. So 6 severity levels is what we have for each time point. And we first extract the CNN features from the patch of a particular grid, say the left uppermost grid or the right uppermost grid. So one at a time we do that. So once we extract the patches from those grids, we fit them into this TCN. It will be a 3-layer TCN. For illustration purposes, I've shown a 2-layer TCN. And the dilation factor basically determines the number of neighbors from which the time point can be can get help from. For example, dilation equal to 1 is equal to 1 neighbor, dilation equal to 2 means 2 neighbors in this way. And there is a self-attention block that by which we are basically computing a self-attention matrix after each of the TCN layer. And finally, we are getting attention weight vector, as you can see from the last layer of the TCN, which is helping us to get the most optimal representation. Like that representation is giving more weightage to the third time point and correspondingly to the other time points. So basically, the third time point in this case contains the maximum information, like where the disease patterns are coming from and what it can be in the later stage. So this is the snapshot pipeline that I've showed it to you. And finally, once we have these frozen optimal representations on the left-hand side, then this in the fine-tuning phase, that is fine-tuning the neural network here, we are getting the snapshot representations on the fly, and we are using MMD to compare it with the frozen optimal representations. And then there is a prediction loss also, which is required for the prediction that we are doing, which can be a mortality outcome prediction or a mechanical ventilation requirement prediction. So any questions on this part?
For your temporal branch, do you have a specific layer you are extracting these features from? Because your output is actually more of a trajectory vector. Right?
Yeah, so the output is basically a 512 cross t-dimensional output, and then we are multiplying it with the attention vector that we have, which is a 1 cross t, like t cross 1, and then we are getting a 512 cross 1 dimensional vector. When we multiply this 512 cross t with the t cross 1. In that case, we can match the dimensions with the snapshot representation, which is also a 512 dimensional vector.
Okay.
So the loss function, as you can see, the MMD loss, if you look at the MMD loss, you will be able to understand. So XS is basically the representation coming from the snapshot. Capital N is basically the total number of patients that we have for the snapshot data, say 1,000 patients. And capital M is basically the total number of patients that we have for the temporal data, which is maybe like 50 patients. And this is the average over the temporal data, and this one is the average over the snapshot data. So MMD loss in this case is basically just a difference it's a Euclidean distance between the snapshot domain and the temporal domain. And the recalibration loss, as you can see, it's a weighted MMD and the prediction loss. So any questions here? We'll then proceed. So these are the quantitative results we have on the chest COVID data set. So there were two data sets. First is the COVID prog, from which we get the temporal data. There were 150 patients from whom we obtained 942 images, temporal images. And the snapshot is basically we pre-trained the self-supervised VIT on unlabeled data sets, but the target data set on which we did the prediction was 631 cases having both the mortality prediction ground truth and the mechanical ventilation requirement ground truth. And these were the methods that we compared against. And most of them were single snapshot pipeline based papers. Our method is the one which uses temporal information as an auxiliary information in order to do the prediction. And it performs better than the others. And the qualitative results with and without using the temporal information, as you can see, the clusters, like the data points are better, the features are better clustered. And the GradCam maps also, it localizes much more on the important parts. On the left-hand side, as you can see, the localization of the GradCams, they become more precise, and some of the unnecessary GradCams, there are some necessary GradCams which we are missing when we are not using the temporal. They are being focused on in our framework. And these are the results on the knee osteoarthritis data, where there is osteoarthritis initiative database from where we get the temporal images. It's a public database, and there are also a Kaggle site like Kaggle challenge on this osteoarthritis thing, from which we get the snapshot data. And what we are doing here is the severity prediction, that is the severity level prediction of this osteoarthritis data. And we compare against like contemporary frameworks like squeeze excitation block or deep knee. These are some of the papers which are out there for this knee osteoarthritis prediction. And similarly, these are the qualitative results. It's a multi-level classification. There are 5 levels, but I've shown here the 3 levels which are the most like intermingling with each other. And this is the SOTA comparison with the other main frameworks on the qualitative side. Any questions here?
So Ashik, if I understand correctly, basically your temporal model, temporal data is coming from a separate data set, right? So it doesn't even have to be like within the same data set.
No, it doesn't.
Right.
Yes.
It doesn't have to be. So it's pretty cool that like it's not only unpaired, it doesn't really have to be from the same source. That's very interesting.
So one thing is that we need to have some amount of the fraction of data which is overlapping. That is the snapshot and the like. Even if there are 100 snapshot patients, we require 5 to 10 patients who have the temporal data. So that's the thing. That can be, we have done an ablation on that side, like when the reviewers asked, but we have showed that even with 5 to 10% data, which is a very low fraction, we can do with the temporal learning.
Okay, that's great.
So the takeaways are that this is the first work that learns representations from limited temporal images and exploits them to improve clinical prediction tasks from snapshot. We use a temp convnet that employs hierarchical attention to get the same dimensional representation also from the temporal domain. And third of all, we use the MMD loss for the first time in a non-generative context. Mostly MMD losses are used in GANs and other generative context to align the snapshot and the temporal feature space. So do you have any questions in the first work? This one? Any more questions?
Hi everyone, just a quick announcement. We are facing some issues with Zoom, so you might see meeting cut off in like 5-6 minutes. If it happens, you can just please join back and restart the meeting. The same goes for you, Aishik. If you see the meeting cut off, you can just join back from the same link that we sent you earlier.
Okay. So this is the another work that we have done. These are the different training strategies to tackle the missing modalities while doing a segmentation task. So I want to like emphasize on why we need multimodal imaging data, because there is an increasing like availability of different forms of data from the EHR, then images, then biosensors and genome sequencing, which can all be utilized for doing a particular task. And they can capture the complexity of, they can better capture the complexity of a human health and disease. So as you can see, these on the left hand side are the different data that modalities that we can exploit, and on the right hand side the different opportunities or the fields that we can apply them. And the right hand side are the combinations or sub combinations of data which we can use in our task, like in radiology precisely, like MRI and CT, MRI and PET scan, or different forms of MRI, different sequences of MRI. So the work that we are showing here is clinically motivated in a way that accurate segmentation of brain tumors, it can expedite the clinical procedures and treatment planning. But standard brain tumor segmentation tasks, they require all the 4 modalities to be there. By modalities, I mean sequences here from FLIR, T1C, T1, and T2 for the segmentation. So all 4 are needed in the conventional brain tumor segmentation tasks, but in clinical practice, only a subset of modalities may be available due to many factors like limited scan time, then allergy of the patients to the contrast mediums, patient movements, erroneous machine settings, and others. So the existing segmentation models, they fail to handle the missing modalities while doing the segmentation. So our goal is, can we train a high fidelity segmentation model which is resilient to these missing modality scenarios. So the technical challenges, so there is a lot of literature handling this problem. So first of all, I can categorize those works. First of all is the knowledge distillation, but a limitation of the knowledge distillation is that they require access to the full modality all the time. So when they are training the teacher network has to be trained with the full modalities, that is all the 4 modalities. So it's basically not a practical solution, because ultimately for training purposes they're requiring all the 4 modalities of the patients, and also it's like computationally heavy, like they require a lot of GPUs to run that. And in the student model, as you can see, they built dedicated student models like T1 student model, T2 student model, and it can go up to combinatorial number of student models, 2 to the power 4 minus 1, 15, if we consider like 15 different combinations. And second of all is a GAN-based image synthesis. But the problem with that is here we are generating a 3D image since we are interested in the volumetric segmentation, and we are generating that 3D image, and we are also dealing with the missing data. So the non-converging nature, GAN is like usually of non-converging nature, and it further becomes unstable when it has to generate these 3D images. And third of all, the model which are most popular around this area are shared latent space models, which generate the missing modalities in the latent space. But can you see now?
Yeah, please.
Okay. So I was here, right?
Yes.
Okay. So the shared latent space models, so what they do is they rely on the statistics, different statistics like mean and variance, to generate those lost features in the latent space, and then do the segmentation after that. So one disadvantage of all these methods is they utilize the full modality or simulate missing scenarios from this full modality during training. So what happens if they do that is they are practically assuming that for the whole data set, they have the full modality for all the subjects. So if I consider DF to be a full modality data set, DM to be a missing modality data set, that is patients having missing data, patients having full data, so their data set capital D is basically equal to DF equal to DM, which is a very impractical scenario. But in our case, what we are doing, our data set, we are dividing it into 2 cases, DM and DF. So DF is basically full modality data, but just for a fraction of the patients, like 30 to 40%, and even 25%, we have done an ablation study. And DM, which is the majority part of the data, is basically a large fraction of the patients having the missing modalities. So we have shifted from D equal to DF equal to DM to D equal to DM plus DF. And now we are trying to utilize those small fraction of full modality patients in a we are trying to leverage them in an optimal way. So what are the things which we are proposing is we are adopting meta-learning and adversarial learning. So what meta-learning does is it can only utilize the full modality data during the meta test, and in this way we can limit the number of full modality samples and yet get the optimal performance. Second of all, it mitigates the bias against rare modalities. By rare modalities, I mean modalities which are rarely encountered during the training. And third of all, the model can be made generalizable across a variety of tasks. So it will not rely on full modality or biasness towards this rare modality. And adversarial learning we are adopting because we are trying to reconstruct the missing modalities in latent space, and further we are trying to enrich the partial modality representations. So this is an overview of the architecture that we have. On the left hand side, this is the meta training, which is going on the partial modality data, that is the patients with the missing cases. And on the right hand side is meta testing, which is operated on the cases with the full modality data, DF, which is basically a small fraction, 25 to 30%. And there is an encoder decoder framework, as you can see, a generator decoder framework, and there is an inner loop gradient update in between the DM and in between the meta train and the meta test. And after each such loop, there is outer loop gradient update. I will go through them in details over the next few slides. And there is also a modality absence discriminator. So here we are using the adversarial learning in this way, that from the bottleneck representation of the generator, we are feeding it to a MLP, which is the discriminator in our case, and it's performing the task of basically doing a multi-level classification of which modality may be there or which modality may not be there from that representation alone. So this is the framework that we have. On the left-hand side is the meta train. So meta train, as you can see, 2 of the modalities are not there, 2 of the modalities are there. So these modalities are dropped in order to create a heterogeneous task distribution. And after that, we are using Swin transformers, that is the encoder part of the Swin unitor, in order to individually extract features from these modalities. And we are fusing them at different levels for the skip connections. So there can be 5 different levels, including the bottleneck. We are fusing the encoded features from these 5 different levels of these modalities which are available. And then we are using adversarial learning in a way that the bottleneck representation is fed into this discriminator, which is doing a multi-level classification that these are not present, these modalities are not present, and these are present. And this bottleneck representation also goes into the decoder, which is basically a bunch of the CNN layers that gives us the segmentation. So the discriminator and the segmentation, they complement each other. And all of this is going on the meta training set. And the loss is calculated for this meta training on the partial modality data. As you can see, this loss is calculated on DMI. So DMI is the data set with the missing modalities or the partial modality data. Same thing is being repeated in the meta testing phase, but with full modalities. So we are feeding here the full modality data to the same framework, the generator. It's a shared generator. And the discriminator is again performing like the task of which of the modalities will be there, where here all the modalities should be present. And this the meta testing and the outer loop gradient update is happening on the full modality data. So the generator theta g parameter, which is learned in meta train, is basically updated to theta g star while testing on the full modality data. So this thing is tested on the full modality data and made to perform better. So the encoder, which is trained on the partial modality data, is tested on full modality data, and the loss is made to perform it better. So in this case, this theta g star basically changes, and we evaluate this loss function of theta g star on the full modality data, and again this cycle goes on. So is there any questions?
Aishik, when some modality is missing versus like all modalities are present, is how do you keep the kind of input dimensionality the same? Is you're feeding some, if the modality is missing, are you feeding some identity vector in place of that modality?
Okay, so yeah, it's a very nice question. So basically, while fusing, there is a fusion module which have not gone through here. In the paper, there is a fusion module which is basically fusing zeros in the places, like appending zeros on the places of the missing modality data. So while we get this bottleneck representation, so the only the bottleneck representation is the one which is like going into this discriminator, and there are other fusion modules which are taking the other levels. So the main point is we are appending zeros if in the fusion module, if some of the modality are missing, we are replacing them with zeros. Yeah.
Okay, thank you.
Any other question? Okay, so the purpose behind the purpose behind our using this discriminator in such a way is basically it it's basically influenced from the adversarial domain adaptation. So it's a sort of domain classifier where the discriminator will force the generator to always basically encode a generate a representation that is representative of all the full modality data, because the discriminator will be very accurate, and it will try to easily classify which of the modalities are present or absent. But in order to fool the discriminator, the generator will always try to generate a representation where all the four modalities are present. In this way, the missing modalities are hallucinated in the latent space. So these are the different, for the feature adaptation, these are the different losses. So we are obtaining an optimal generator theta g, as I said during the meta training, through this task-wise training on the DM dataset, that is the missing modality dataset. And by task-wise training, I mean that I'm considering each combination of modalities as a task. So if there are 4 modalities, there can be 2 to the power 4 minus 1, 15 tasks, and one of them is the full modality task, which I'm reserving for the meta testing. So the remaining 14 are combinations, are the 14 task-wise training which I'm doing on the meta training. And the goal is to test this updated framework theta g star on the DF, that is the full modality data set, where the only task is the getting the segmentation from the predicting the segmentation from the full modality data. So if our missing modality model, which is the meta training model, can do well on the full modality data, then our features are slowly getting adapted from the missing latent space to the full latent space. And finally, as I showed, all these 3 meta parameters after one cycle of training, that is meta training and meta testing, are getting meta updated over a meta batch of tasks. And now we are going through the feature enrichment. So feature enrichment is basically the discriminator and the generator. So for the discriminator loss, we are considering the real combination of modalities encountered at the iteration. That is, for discriminator loss, like discriminator loss is basically a binary cross entropy loss, but this T real which you are seeing here is basically the real combination. Like if T1 and T2 is not there, T1C and FLAIR is there, then we are having a vector like 0, 0, 1, 1. But for the generator, this ground truth, we are setting it to a dummy variable of 1, 1, 1, 1, depicting that all of them 4 are present. So as you can see, the discriminator, the T real, is basically the correct combination of modalities at that particular iteration, but T dummy is basically all the combination of modalities, like the full modality. So this one is for fooling the generator to produce full modality representation. And I did a small experiment which you can see here. It's a T1 and FLAIR missing scenario. So on the left hand side is M drop. M drop is basically a baseline which doesn't use the partial and the full modality. And on the right hand side is our framework which uses the M drop is the one which doesn't use the adversarial and the meta learning strategies. And on the right hand side is our framework which exploits both of them. And in T1 and FLAIR missing scenarios, so these are the probabilities of predicting a modality from that bottleneck representation. So the probabilities of finding T1 and FLAIR in our baseline is very low because it has not been trained with T1 and FLAIR. But on the right hand side, you can see that the probabilities of finding T1 and FLAIR is very high because of due to this feature adaptation that we have, where our generated representations are mimicking the full modality representations. Any questions here?
So this is not the final downstream task prediction performance. It's the modality prediction performance.
Yeah, it's a intermediate thing in order to. It's a concept idea.
Concept idea. And
Proof of
how
concept.
are you evaluating it on the quality of the generated missing representation, or just that it's? I mean, what is the what are you representing at the y-axis? Exactly, like how is it? It's able to predict. How do you decide that? Is it a good enough representation of the missing data?
Because it's able it's a multi-level classification. It's trying to these are the average probabilities of predicting a particular modality in that bottleneck representation. So it's able to predict that T1 is there in that representation. So even though it's like making it like more like in a full modality representation, ideally it should be one probability in all the four modalities, right? So in our case, it's getting like more probabilities of predicting T1 than the baseline, where the baseline is like 0.4. So it's saying that in the bottleneck representation, the features of the T1, identifying T1 are very less. So that's why its probability of finding it is also very low.
So basically, it's if it's the performance when your predictor is able to say that yes, there is T1 available, even though T1 was missing originally.
Yes. Yeah.
Okay. And as to how good is or how relevant is that representation of T1, I think that's kind of left up to the downstream prediction performance.
Yeah, I can show you the quantitative results. So I did the experiment from 3 data sets, that's 2018 to 2020, and I have shown the results for only 2 regions here: whole tumor region, the tumor core region. There is another region called the enhancing tumor region, and these are the different cases of the inference scenarios, like 15 different cases, where only the dotted ones are available in the inference phase. For example, in this particular experimental setting, only T2 was available for all the patients in the inference phase. And again here, on the next column, only T1C was available. In this case, in this way, only these particular combinations were available for the patients, all the patients in the inference phase. And our main goal was to lift this performance of when we only have a unimodal or a bimodal cases for the patients, how we can make them like as par with when we have full modality, so to this 91.26. So most of the other methods, these are the relevant methods which deal with the missing modality. They do good when 3 or 4 modalities are available, but they perform poorly when some of the major modalities are missing, like a FLAIR or T1C. FLAIR and T1C are some of the modalities which influence a lot the performance of the whole tumor or the tumor core part. So whenever they are missing, as you can see for the other methods, when FLAIR is missing in this case, so other performance are very like 81, 84, 85, but we boosted the performance over the D2net, UHVD and HEMIS. But ACN, RFNet, former, we were at par with them. But there is a catch that all these 3 methods, they utilize the 100% full modality during training. But in our case, since we are following that D equal to DM plus DF criteria, so we can only do away with 30 to 40% of the full modality. So during training, we are using the full modality for the meta testing part, but during their training, they're utilizing the full modality for all samples. So yeah, our method uses 50% full modality and still outperforms the SOTA by 11%. This 11% basically comes from another table where I have also trained those SOTA methods like ACN, RFNet and former with only 50% of the data, and they were performing a bit worse because in their case, if I train with less full modality, it's like reducing the number of overall data samples. So that's why their performance drops, and we were able to beat them by 11%.
Very interesting, Aishik. Quick question. Yeah. When you this dotted representation, it represents that okay, in the first column, T2 was present for all of these samples, but does it mean that FLAIR T1 and T1C were maybe present for some of these samples?
They were present in the training, but this is during the inference phase.
You just say, okay. So in the inference time, only T2 was present for
Only
all of
T2 was
these.
present for all the test split.
Oh, okay. That's very interesting.
Yeah. So these are the few ablation experiments to support our claims. This is the robustness to proportion of full modality in the training. So as you can see, the other methods like SCN, RFNet, and MMFormer, which were also doing good. So when the number of full modality cases were basically dropped from 100% to say 40%, their performance degraded a lot sharply. And these are the three different plots for whole tumor, tumor core, and the enhancing tumor performance. Whereas on the our performance, which is on the red, you can see if I drop the full modality data from 50% to 40%, our performance on the red is basically just it's not like declining that sharply as the others, because of the only thing is that we are utilizing full modality in meta testing, whereas they are utilizing for training the whole data, training the whole model. And another aspect that we are unbiased to presence of a rear modality was basically we synthetically, the rear modality in this case is T1C, we synthetically limited the number of times T1C was encountered during the training from 45% to 35%. And as you can see, the others like D2Net and our D2Net and UHVD, which are the shared latent space models, they were declining a lot more like sharply than we did. We also did an effectiveness of like study to highlight the importance of each of the module that we have, which is the adversarial part and the meta learning part. And this is the comparison with the 50% full modality. Like the table on the last slide that I showed was others methods were also trained on 100% modality samples. But here you can see that ACN, RFNet, and MMFormer, they are trained on with 50% full modality samples, and how their performance like drops comparing to ours. So yeah, we have two major takeaways from here. That is the quality of the segmentations. Yeah, the quality of the segmentations here is basically they are not dependent on the presence of a particular modality, and the generated representation is not biased to the number of times we encounter a modality during training. So these are the qualitative segmentation maps. So the left-hand side, the left-hand column is basically the images that we have of this patient, flare T1C, T1, and T2. The right-hand side is the ground truth that we have, which is the same in any combination that we take. And you can see the lowest most row is basically where we have all the full modalities available, flare T1C, T1, and T2. So the three columns are basically UHVD, RFNet, and our method. So when we have flare T1C, T1, T2, all the full modalities available, then their performance and our performance are mostly similar, at least RFNet and our performance. But whenever the modalities are dropped, that is only flare T1, that is only flare T1C and T2 is there, which is T1 is dropped, then their performance like worsens a lot. Whereas when T1C and T2 is only there, the other two are dropped, then they start like giving bad segmentation output. And finally, in unimodal scenario where only T1, T2 is there, so our performance is much better. Like the whole tumor is 82, their whole tumor performance score is 80, our tumor core is 72, their tumor core, RFNet's tumor core is 64. So our performance is much better in unimodal and bimodal scenarios. I showed another example here, so you can see. So any questions here?
I think we can move forward. Okay.
So these are the three takeaways. We are presenting a novel training strategy to perform brain tumor under limited full modalities supervision with missing modalities. We are adopting meta-learning to mitigate the bias towards rare modalities and by using the full modality only in meta testing. And we are employing an improvised adversarial learning in the latent space to generate superior modality agnostic representations. So quickly, I want to go through two of my previous methods, which was also using limited data, limited temporal data, but temporal data, though it's limited, it has some dense information. So I was able to like model jointly the spatial distribution and the temporal distribution of these patterns in the temporal data. So my goal was to learn the imaging evaluation of a disease pattern and predict severity at a future time point, for which we only have the image, we do not have the ground truth. So it was a two-stage LSTM architecture. So these are the different like images coming from the different time points. We extract the patches from the corresponding grids and we feed them into an encoder. This encoder is basically a patch CNN LSTM block at first. So patch CNN LSTM block is getting the patches and then getting the CNN to extract the features from the patches and employing a LSTM. This LSTM, we are calling it as LSTM spatial because it has information from only a particular time point and it's basically exploiting the spatial distribution of the patterns within a particular time point. Once we have from the last cell state of this LSTM, the representation, it's then fed into the units of the second LSTM, which is called LSTM temporal. So LSTM temporal is basically having like inputs from the different time points and it's able to capture the progression pattern. So like we did it in 2020 and in 2022 or 2023, there is a transformer paper which came out on the same idea, which is VIVIT, video VIT. It's also doing the same thing using the spatial and this temporal representation with two different transformer architectures. We are doing it with LSTM because back then in 2020, like we had very low data, temporal data, and LSTM transformers were not that popular. So what we are doing is basically in this encoder decoder architecture, we are trying to get the severity levels of a future time point, like 2 days or 5 days later, of which we have the image, but we do not have the patients, like the severity levels for that patient. We are trying to predict it. And yeah, this is a joint modeling of the spatial and the temporal patterns. And so any questions on this one?
I think we can keep moving forward.
Okay, I will probably skip the next one because it will take some time. So do we have like 5 minutes more?
We have 3 minutes left. So if you want to skip that, then I can open the floor for questions.
Yeah, I can skip that. So yeah, so any more questions?
Okay, Aishik, first of all, thank you very much for this very interesting presentation. So I think we should give our speaker a virtual round of applause. And then if you have any questions, please raise your hand or just ask. I think we already have one question in the chat. That is the code or model available for your?
Yeah, for the 2 LSTM works that like I did and one I skipped, and the code is available. But for these 2 works, we are also like they are extending. They're on the process of extending to a journal. So once that is accepted, we will get the code.
Okay, one last question from my side. If this missing modality work, did you do any experiments to see like with like what's the limit on the missing portion of the data? Like how much of the full modality of the meta testing part, which contains like all of the modalities, how large that needs to be to do meaningful learning for the missing data?
Okay, so for meaningful learning, we were able to like shift to 70-30 split, and or 70-30 is the most of like it's not the optimal, like 50-50 obviously is the most optimal. The more we have full modality data, the more the good. But 70-30 is the one which is the benchmark below which if we have less number of full modality below the 30 fraction, the performance is dropping a bit.
Okay. Okay. Still, I think a pretty good performance. Okay, I don't think we have any more questions questions from our audience. So if anyone has any questions later, we can put you in touch with the speaker. You can always catch us on email. Okay, Aishik, thank you very much for joining. And thank you very much for this interesting talk. We will upload this on YouTube in the coming few weeks. Thank you, everyone.
Thank you, everyone. Yeah.